Yeah, thank you very much, Pera. Thank you very much, Poppy, for inviting me. So I will have a view as a pediatrician, and as you know, we see fever every day. And it was actually Antoine de Saint-Exupéry who realized that not everything which is fevers is infection, so maybe you have to think a little bit out of the box. So when I got this title, I was actually shocked because I put primary immunodeficiencies, autoimmunity and therapy, and I got over 700 hits. Then I said, well, let's put children in this, and I still have nearly 300 hits. Then I thought, why don't I put my name in this, and I have 4. That was quite nice, I thought. But what I will do is try to speak what we know and what we would like to know about treatment of primary autoimmunity and primary immunodeficiencies. I'm not going to speak about CVID, and I hope it's not going to be boring. I'd rather be ridiculous. So Paul Ehrlich was actually wrote very nicely this observation of horror autotoxicos. That was his definition in 1906, I think. And it was in the late 50s when Kunkel in the States, he made an observation comparing serum from patients with rheumatoid arthritis, which are here, and controls. And what he saw an extra band and a high molecular protein, which subsequently was called the rheumatoid factor. So that was just a little bit of background. Probably the idea of to get autoimmune disease, you need 3 things. You have your genes on the one side, the interaction with the environment, and your immune system. And is it worthwhile to speak about it? Obviously, this is still the major paper which was published on over 2,000 patients by Alan Fisher and the French PID study group. And what they showed is that basically more than a quarter of the patients who had a primary immunodeficiency suffered from some sort of autoimmunity or autoinflammatory disease. And most frequent was autoimmune cytopenia in over 30%, gastrointestinal problems in nearly 25%, and skin and rheumatological disorders in over 10%. And the type of primary immunodeficiency has an impact on the probability to suffer from an autoimmune defect. So if you have a T-cell defect, you're more likely and during your life to suffer from these events. And not surprisingly also, if you have an autoimmune manifestation in the context of a primary immune deficiency, you are doing worse. So there are many causes who can induce immune dysregulation, such as peripheral tolerance, central tolerance, etc., etc. I will focus on T-cell signaling, and even there's so much to be told, which I will only talk about 3 things, because basically that's where I have experience with. So when we are thinking about immunotherapy, ideally we want to be very selective, specific, and the best would be even to cure. And you have in this schemata, very simple, you have on the left-hand side autoinflammatory diseases, where Benedict will speak about this, where at the moment we have a lot of cytokine-directed therapy, and I will speak a little bit more about autoimmune diseases, where we are looking at T and B cells to treat. But before we treat, we have to think what we have to prevent, because whatever we do, we put the patients at risk to encounter infections. And last year, the ESCMID study group, they published 9 documents actually on this, what to think about and evidence-based and what to put in order to prevent it. And just to summarize, there's very basically, the first thing is to avoid is you have to screen and you have to treat. You have to vaccinate the routine vaccines and extra before and after initiation of immunomodulatory therapy. Don't forget about the households and prophylaxis, although there's not much evidence according to the level of immunosuppression. But probably the most important thing is to be aware and to educate the patient, the family, the clinicians, and the nurses. And you really have to not only to know what you are doing, you have to know what your colleague is doing. And you have to look for the right bugs. And as with ACID, really important, collect data in form of a registry to share information. So I'm going to present this boy. We saw in 2014. He had suffered from episodes of gastroenteritis and recurrent respiratory infections. He had some problems with the skin, and he had low levels of IgG. And he had a worried mother. And why was the mother worried? Because actually, since childhood, she had a lot of problems with chronic diarrhea and renal involvement, chronic skin diseases. She's on IgG substitution she's over 20 years for CVID. So now we had a worried doctor. And when we went through the family history of the 3 generations, we saw that something is going on. There's a familial hypogammaglobulinemia. Everything what is in red is some sort of autoimmune or autoimmune pathology. And then at that stage, we didn't really know what to do with this, so we called a friend. And why did we do this? Because in 2014, these 2 papers back-to-back came out in Nature Medicine and Science, who described a dysregulation syndrome due to CTLA4 mutations. Just to remind you, CTLA4, and you see here, this is a T cell, this is an antigen-presenting cell, so CTLA4 competes with CD28 for CD80, CD86, and basically is an immune checkpoint to stop activation. So LRBA is a cytoplasmic molecule who binds to the tail of CTLA4 and enhances or CTLA4 recycling and prevents degradation. Now, if your CTLA insufficient due to the numbers or functionally, you are not able to stop a signal, and you will have an ongoing activation. So when we looked at our patient cohort in Sevilla, you can see in red these are all affected patients, and in green they have the same mutation. Obviously, they didn't have any symptoms. So that is also something to keep in mind when we look at mutations. So then a year later, this was published, the biggest study so far on over 130 patients worldwide. And as you're very well aware, the majority of these patients had hypogammaglobulinemia, lymphoproliferation, hematological involvement, respiratory, etc., but also 30% had some neurological involvement, interestingly. And when you look at the treatment overall at that stage, I mean, obviously steroids still was used in the majority of cases and immunoglobulin substitution, but also some targeted therapy in 40, 30, and 25% was used. And a more updated list of the effects and side effects of this patient group showed that rituximab, maybe in summary you can say yes, and 2/3 of the patient, it had a positive impact on ITP and autoimmune hemolytic anemia, but obviously you have a risk to lose your B cells. Sirolimus in half of the patient probably improved enteropathies and also some cytopenias, but you have problems with infections, and also quite a few patients have after ulcers, which result in that you have to give lower doses of sirolimus. And then finally, abatacept was used in 2/3 of the patients with positive effects in terms of improving her enteropathy and lung and CNS and lung infiltration. However, there's no increasing data that you might have problems with norovirus infection and other reactivations of viruses. So just to mention, so abatacept is mimicking CTLA4 function. It's an IgG fusion protein, and as I said before, it competes with CD28 and inhibits thereby T-cell activation. And just to mention, there's a paper in progress to be submitted by the team in Freiburg on a worldwide paper where they look at treatment options and treatment results on a total of over 123 affected CTLA4 mutation carriers. And it's very practical. It's going to be a chart like this one on the right about the most important clinical presentations. And also in theory, just on Wednesday, 2 days ago, which coincided with our meeting, there should have started a safety and efficacy study on high-dose abatacept to treat chronic cytopenias in CTLA4 haploinsufficiency patients. The next case is a girl we saw 4 years ago, 2 years old, with adenitis. She was drained, and she had a streptococcus pneumonia. And basic immunology bloods, you can see they have a very low IgG, very high IgM, and then she also had reduced class switch memory B cells and high transitional B cells. Well, at that stage, we thought maybe this is like an autosomal recessive hyper-IgM or hyper-IgM-like syndrome, started immunoglobulins, but with very poor response. And then in Freiburg, they found a de novo mutation of PYK3R1, and she was started on sirolimus and improved significantly in terms of her lymphoproliferation. And also, interestingly, her growth and weight gain improved. However, she didn't manage to, she suffered from ulcerations because of sirolimus, and that had to be reduced. This is also a paper you are aware of. This was the biggest paper on 53 patients on APDS1. And I just wanted to point out the high percentage of autoimmunity which was observed in these patients, and that was even higher compared to CVID cohorts. And here we have a summary where we compare type 1 and type 2, and that basically there's not much differences in the clinical phenotype and also in the management, but probably, as it was in the case of our two patients, if you have APDS2, you're more likely to have problems with microcephaly and failure to thrive. It's only two patients, very careful observations. This is a very, very great evidence of how good it is to have registries. So here you see the disease evolution of APDS1 and 2. And just to say, by the age of 5, nearly 90% already have problems with respiratory infections, 75% have problems with lymphoproliferation, and then cytopenias, they kick in a little bit later in life. And when you look at the treatment used at the age of 10, probably you can say that half of the patients are receiving, half of patients receive immunoglobulin substitution, and about 25% either steroids or some sort of an immunosuppressive drug. And the impact of sirolimus is also nicely illustrated in this paper. Just to summarize that complete remission or partial remission was achieved in terms of lymphoproliferation in 75%, cytopenias in 40 and 36, sorry, and colitis in 40. However, there were also one case each who worsened whilst receiving sirolimus. So the idea is, how do you get an uncontrolled T cell into a controlled T cell? There are two targets. One is the P110 delta, and you use a small molecular inhibitor such as idalicizib or leniolisib. I don't have experience with this, but the idea is to inhibit PIK20, and the other target is just to use sirolimus, what we did with our patients, and it's an mTOR inhibitor with the aim to reduce autoimmunity and antibody deficiency. And there's evidence that it works. This is an open-label, non-randomized dose-escalating study where they basically wanted to show that they're able to suppress PIK20 overactivity. They're able to reduce lymphoproliferation and normalize the immunophenotype. And indeed, after 12 weeks, when they looked at it, they could reduce lymphoproliferation, they normalized the immunophenotype, and also there's a dose-dependent reduction of PIK3CA activation using leniolisib. And there's an ongoing phase 2 study now in looking at efficacy. So this is a girl, 5 years of age. I'm a pediatrician with Down syndrome and progressive interstitial pneumonitis. Impressive lung pictures here, and she also had recurrent and treatment-resistant candida. Her lymphocyte sets were normal, memory B cells less than 2%, but keep in mind she's only 5 years old. Normal immunoglobulins, and she was found to have a variant mutation in STAT1. It's the same as the mother who suffers from CMC. And yeah, we are quite excited. In Severe, we started now a few months ago to look at monocytes and STAT1 and phosphorylation of STAT1. And what you can see is it's just starting, but basically the mother, the healthy control, the mother and our patient, Daniela, on treatment. And it appears that actually STAT1 is a little bit reduced compared to the mother who's not on treatment. So ruxolitinib in vitro has this effect. And the same when you look at the phosphorylation of STAT1 also seems to be a bit reduced looking in monocytes. But much more important is the fantastic clinical effect. In 20 months now she's in treatment. So we were able to stop her steroids. We stopped her anti-pulmonary hypertensive therapy. She obviously continues on some prophylaxis, but she's on no oxygen requirement or reduced. She hasn't been admitted for 12 months. And definitely, as you can see, it's a Feria and Sevilla. She's dancing. Her quality of life has improved. And another patient with STAT1 gain-of-function mutation is Carla, which we saw at the age of 11 years. She had a recurrent stomatitis, some infections, recurrent candidiasis, and sadly, at the age of 10, she suffered from an intracranial bleed due to an aneurysm, which required an embolization. And then she was also subsequently, because of this event, diagnosed. And here, it is, again, it's only one patient, but you can see with a little bit of imagination that the dose dependent, if you see here on 5 milligram using every 12, and here on 7.5, it appears that pSTAT1 is a little bit better controlled, yeah? So this is a work that's done by Pilar and Peter Olbrecht. And this is obviously the summary of the biggest paper published so far in 2016 on over 180 patients. And just to remind you, infection is a big issue. Nearly all of the patients have CMC, but bacterial infections are very common, as are autoimmune diseases. And don't forget about the possibility of a vascular insult. Immunology, very basically, interleukins are raised. IL-17 producing cells probably are increased. It's not so clear, but there's an increase of pSTAT1. And the management is a bit frustrating. It's supportive, but targeted therapy in form of ruxolitinib seems to work. And the idea is, the proposed effect of this is that it inhibits the phosphorylation, it normalizes the proportion of Th1 and Th17, it cures infection, and it keeps cytopenias in remission. But you have to be aware that you really have to monitor full blood counts and lipids, because there are quite severe side effects, such as bruising, pancytopenias, and serious bacterial infection, and also hepatitis. And again, just very schematically, the idea is using a ruxolitinib as a JAK1/2 inhibitor to inhibit pSTAT1. And these are papers you all very well know, but I think it illustrates that ruxolitinib probably has a role. It improves CMC on the left side, improves alopecia in this patient. So that is quite nice. And then this paper summarizes 17 patients, 11 with STAT1 and 6 with STAT3 gain of function, who received JAK inhibitor. In case of STAT3, they also added in tocilizumab. And the outcome appeared to be very good. 14 out of 17 responded initially. However, 4 patients overall died. And I just wanted to mention this patient who had severe gastrointestinal problems. These are stool output. He was on total parenteral nutrition. Once I started on ruxolitinib, his stools went down, and he also could start to eat. And what is the role of hematopoietic stem cell transplantation for STAT diseases? And this is not very complete, but more or less, I think we can say from the papers that half of the patients actually die. So there is still to think who is probably the right patient to be transplanted. And there are a lot of side effects, yeah. This is our experience in Sevilla, what we have used in our patients. It's just a summary. And I want to leave you with I think what we know in summary is that some pathways appear to work, such as abatacept and CTLA4, LRBA deficiency, sirolimus for APDS1 and 2, and ALPS, JAK inhibitors for STAT1 or STAT3. But what we would like to know, or what I would like to know, is how can we prevent off-target effects? How much do we actually need? What should we measure? How long do we have to treat? When can we stop? What is a long-term requirement? And is there a need for an additional immunosuppression? What are the adverse effects we are expected on the short and on the long term? And as I mentioned before, who is actually eligible for a hematopoietic stem cell transplantation? And finally, I didn't speak about the role. Is there a role, and if so, what is the role of gene therapy or editing in these patients with gain of functions? So I think it's all about communication. Everybody here is working on his field as much as he can do. Nobody's better or worse, but we just have to work together. And I like very much this. When I was in Ireland last year, this is the oldest pub in Athlone, where they say everyone brings a little bit of happiness to this place, some by coming in and some by going out. And thank you very much for listening.